Okay, so for this presentation, I will go over a case study of an individual with major depressive disorder, diagnosis, assessment, and treatment. So I won't read every slide verbatim, so just try and follow along. If you want to review the slides in more detail, you can do that later. However, this individual is 19 years old, fairly young. William Perry, biracial, white and half Asian, bilingual. So a little bit of background: mother and father, a history of abuse in the family, verbal abuse, threats of violence, yelling, a history of mental illness in the mother, bipolar disorder. Siblings, two siblings, brother, mild intellectual disability, sister, physical aggression with the father, brother, physically violent. So some symptoms that have been going on for a long time for this individual started back in high school and possibly into middle school. These symptoms started: frequent crying during school classes, at home, feeling like he doesn't have enough energy, no energy to the point where he feels like he's kind of sleepwalking, kind of walking through the day, wanting to go back to sleep, just very tired, like the 8 hours, 10 hours of sleep did nothing. Another symptom, he notices that there's lots of poor concentration during work, during college, just feeling like very, very tired because of his depression. So we do have to collect some more information on this individual in order to better diagnose, treat, create an intervention plan for him. We'll need things like history on his family history, on their medical history, see if there's any predispositions to things, maybe genetic influences, his own personal medical records, more information on his social life, and see if he has any prior diagnosis. So how will I engage with this patient during treatment? Well, we always want to tailor communication to the needs of the individual. In this case, I would want to be sensitive to an individual who's biracial, so keeping in mind the cultural values of someone who's Asian, also white, making sure there's no offensive terms for either race. In this individual's case, because of his personality, he's using short sentences and phrases. I want to make sure that my questions are short, direct, so that they're easy to answer for him. So the DSM-5 outlines the criteria for a diagnosis of major depressive disorder. It requires at least 5 symptoms in order to be diagnosed, going on for at least 2 weeks. But in this individual's case, it's going on for a few years. So he definitely meets the minimum requirements and most assuredly has more than 5 symptoms. So the symptoms of the patient, I won't read them all, but here they are. Again, we talked about fatigue, depressed mood most of the days, because that's been going on for years. Sleep, insomnia, even when he gets to sleep, it's like it does nothing for him. So definitely have exceeded those minimums requirements. So DSM-5 has specifiers for major depressive disorder. In this case, his symptoms, he also has symptoms of anxiety. I believe it's 3 or 2 minimum symptoms needed to reach the specifier of anxiety, distress. Again, feelings tense, fear that something awful will happen. Again, that kind of anxious mindset that comes when you have anxiety, always kind of fearing the worst. Okay, and also DSM-5 wants to specify the severity of the the symptoms, the condition. In this case, he has at least 3 symptoms, so we put him at the moderate level from major depressive disorder. So things that are going good for this individual, him living on his own is a sign of resiliency. He's able to take care of himself. He has a natural desire to recover. He does show some improvement since moving out on his own naturally, so he's not permanently damaged at this point, and he's not entirely. So that's some protective factors. So we want to rule out what diagnosis he doesn't have. We don't want to give an improper diagnosis. It's not social anxiety. We know he wants to have friends. He does like to socialize, and we'll get into some reasons why he doesn't in a little bit. So there's some room to improve with social skills, but it's not meeting the requirements for a diagnosis. And also, he's not on any kind of medications or doesn't have another diagnosis that would otherwise explain his symptoms. So we want to be more accurate. We want to be sure that we're giving an accurate diagnosis. We could administer this depression assessment tests, such as the Beck Depression Inventory, the Hamilton Rating Scale, if we want that more concrete diagnosis. So part 3 of this presentation, critical analysis of evidence-based treatment approaches. We would go into, for this individual, CBT, cognitive behavioral therapy, as it seems that this patient his distress is coming from the memories or the thoughts of his traumatic childhood and just not being able to control those negative thoughts that come. So researchers found a correlation that showed positive link between things like cognitive behavioral homework and therapy. So the more therapy tools, such as written exercises in CBT, and we'll get into an example in a little bit, the more likely they're to improve. So one of those CBT tools is the Daily Record of Dysfunctional Thoughts. That's by Dr. David D. Burns, one of the leading experts on cognitive behavioral therapy. And this is a written exercise. So on a sheet of paper, they'll make columns, one titled situation, their emotions, their thoughts. Then they're going to identify the more logical response to those thoughts and emotions and counter thoughts to kind of challenge those negative self-talk. So this intervention plan is going to take the form of an ABAB design. So we're going to start off with baseline, go to intervention, another baseline, then end with an intervention. And this research shows that this helps us establish, is there a link between the intervention and the changes in the behaviors we want to modify. So in this case, the depression, we want to reduce depression. So we have to quantitatively measure his depression. So we can do that using a tool by Dr. Aaron Beck. It's called the Beck Depression Checklist, and this is a page where they'll answer a series of questions and assign a number to each question, rating how the severity of their symptoms for that one question. And at the end, they'll get a total number. And our goal for this patient is somewhere between 0 and 5, because even people who don't have a diagnosis of depression, they're gonna have some feelings of sadness. They won't always answer every question with a 0. So there's something there. And even though there's something there, that doesn't mean he has, that they have a diagnosis of depression. So we want to get him down to kind of what we say the normal range, 0 to 5. Okay. So estimated duration of therapy, again, the typical duration is 12, but based on the severity of his symptoms, and then we would say probably 24 sessions, which he will be able to pay. But again, 12 is the ideal range, but again, it all depends on the severity of the patient. We're not going to kick them out because they need an extra few sessions or even double. It's just as long as there's a therapeutic effect, we'll keep seeing them, and if they're making progress and they're getting the best treatment, then we'll do that. So he'll need double just because of the amount of time he spent being abused at home. So the good thing about CBT is it can be adapted to different cultures. So in this individual's case, Asian, white cultures, researchers, they created CBT to include differences in, say, like the language of a particular group, their beliefs, things unique to the culture. Again, you can, with CBT, you can modify written exercises, um, the discussions, to the needs of the culture. So it's very open-ended. It's definitely most appropriate for this patient. So in conclusion, what I learned from this case study, this assignment, is to identify the disorder before we pick what type of therapy approach we're going to use. So I can't just jump to CBT for everybody. I got to know what's their diagnosis, what works for the patient. And trying to make sure I figure out a way to quantitatively measure progression if possible, because we want to see, are they actually improving? I can't just rely on my memory or what feels like improvement to me. I want to make sure that they're really getting a therapeutic effect. I think it's going to be hard to collect information from the patient. Sometimes they may not have records available. We don't all have, our medical records from when we were kids, or mom didn't keep a file of our shot records. So that might be a challenge for me. But so those are some of the things that I've learned from this assignment. I think is really good. And these are just my references. The reference I recommend for everybody's read is Feeling Good, here at the bottom, by Dr. Burns. Again, one of the best books out there for treating people with depression. And that concludes this presentation.